Afternoon, everyone. My name's Stephen Scott. I am the manager of the Suicide Prevention Portfolio at the New South Wales Ministry of Health, and welcome to this webinar on the Towards Zero Suicides Alternatives to Emergency Departments initiative, and in particular the co-design work associated with the development of that initiative across New South Wales. I'll start by acknowledging the traditional owners of the land on which we're recording this webinar today, and also acknowledge the people with lived experience of suicide who are participating in or watching this webinar, and particularly acknowledge your contribution to suicide prevention. I'll start by giving an overview of some of the policy settings and an introduction to the initiative itself. But joining us on this webinar today, we also have David Alcorn, the Clinical Director of the Illawarra Shoalhaven Local Health District Mental Health Service, Bronwyn Edwards, the CEO of Roses in the Ocean, who have been engaged to work on the co-design of the Alternatives to Emergency Departments initiative, and Carrie Lumby, who is a lived experience member of the Illawarra Shoalhaven Suicide Prevention Collaborative and a member of the Illawarra Shoalhaven Local Health District Towards Zero Suicide Steering Committee. And what we are particularly focusing on in this webinar is reflecting on the process and learnings from the co-design that's already been undertaken, managed by Roses in the Ocean in the Illawarra Shoalhaven Local Health District, which is the first site in New South Wales that has undertaken the co-design work. So this webinar is being produced to share with other districts all of the reflections from that experience in Illawarra Shoalhaven. Now, just to zoom out for a moment, the policy basis of the Alternatives to Emergency Departments initiative is the Premier's priority on Towards Zero Suicides and the strategic framework for suicide prevention in New South Wales up to 2023. And particularly linked with that is a range of initiatives that we refer to as the Towards Zero Suicides initiatives. There's 15 of them in total, and the Alternatives to ED initiative is a major component of those 15 initiatives. You can read more about all of those initiatives on the New South Wales Health website. Now, just to speak a little bit about the origin of the Alternatives to ED initiative approach, the lived experience movement has been calling for many years for there to be a new type of suicide prevention service, which is a non-clinical alternative to emergency. In New South Wales, we particularly looked at the emerging evidence base that has come about from the very innovative implementation of these kinds of spaces in the United Kingdom initially, where some quite compelling evaluation evidence was found of a reduction in mental health inpatient admissions by a third in the catchment areas of these types of services. And then we've also looked to similar models and trials that have been undertaken in Melbourne and also in Brisbane, as well as the example of the Crisis Now program in the United States as well, that also provides these types of non-clinical alternatives for people who are in a suicidal crisis. The origin of the design of the initiative really began last year with a statewide workshop and forum that brought together a range of similar programs, some of which I've just mentioned, and a range of suicide prevention experts, including people with lived experience and representatives of every local health district around the state, to design some consistent statewide essential elements or statewide requirements for the Alternatives to ED model. And coming out of that has been firstly a statewide requirements document for the Alternatives to Emergency Departments initiative, which contains some key objectives and some of the values basis of the model. and give some further implementation advice both at the statewide and local level. Most importantly, it identifies some essential elements that are to be incorporated and built on in all of the implementation sites. And they include that there be leadership by people with lived experience of suicide, that there be due attention to safety and accessibility for the service. And by that, we're meaning that there's a no wrong door approach, that there is not a requirement for people to present to an emergency department first in order to access the service, and that essentially there be as welcoming and accessible an approach as possible to people being able to use the service, and to not necessarily have to meet certain eligibility criteria or go through assessment processes in order to receive support there. Importantly, the model is non-clinical. So clinical services are not provided in the alternative to ED space, and that what is delivered in the service must be non-clinical. Now, around the staffing with this, many of you will be aware that there is 3 FTE being made available for the staffing component of the initiative, or at least that have been costed as part of the funding model. That includes 2 FTE suicide prevention peer workers and 1 FTE for a service manager position. And that is a broad-based position. It's not required to be a clinician. And if the person in that role is a clinician, then of course their role is to manage the service rather than to deliver clinical services through the through this non-clinical space. And then a few final points that are essential elements for the initiative: that there be recovery-oriented support provided, that there be transparency in the operation of the service, and that there be fidelity and integrity in the translation of the co-design outputs into service delivery. Now, that statewide requirements document is available from the Ministry if you do not already have a copy of that yourself. That has circulated in draft form for several months following the workshop, and there's been a number of iterations and revisions to it on the basis of the feedback from districts, other stakeholders, and people with lived experience of suicide. Now, moving on to discuss the next stage of this design process is that Roses in the Ocean, as I mentioned, have been contracted by the Ministry to support the establishment of the alternatives to ED or safe space services. And alongside with that, Roses in the Ocean have also been engaged to train people with lived experience of suicide in the same sites as the alternative to ED spaces. So there's both a building of community capacity to participate in that co-design process and to participate more broadly in suicide prevention at the local level, and then also the co-design of the local alternative to ED safe space that's drawing on those statewide requirements and customising them for the local environment. Now, as I mentioned, the Illawarra Shoalhaven Local Health District has been the first site for the co-design work that's been undertaken. So I'd like to introduce David Alcorn now, the Clinical Director for Illawarra Shoalhaven Local Health District Mental Health, and ask David about firstly his reflections on the Illawarra Shoalhaven experience of the co-design, and how that compares to previous experiences, and any of the most important reflections that you've taken from that experience, David.
Thanks for the question, Stephen. it's been a really interesting journey. Co-design and working with consumers has been part of my professional life for about 10 years now. I must say this process has taken it to a new level in terms of sophistication of the approach, but also the care. Stephen mentioned a conference last year, which involved a number of consumers, consumer organisations and carers and clinicians as well. I had the good fortune, I don't know if Bronwyn remembers this, to be sitting at her table. And I recall numerous times during that session, watching her after someone had spoken of their experience, watching her get up and support people as they needed to, sometimes for quite long periods of time during the conference. And that to me underlined what this is all about. It is about care of other human beings. And Bronwen and Roses in the Ocean really illustrated that beautifully for me. The work in the Illawarra Shoalhaven comes against the background of a very long-standing suicide prevention collaborative in this area, which has got very good buy-in from our local business community, our primary healthcare network, and from the Illawarra Shoalhaven local health district as well. And that has been a great test bed. It's been great soil on which this initiative has been grown. Why do I think it has come to the next level? I think the level of sophistication in terms of recruitment, support, decision-making, and combining the views of consumers and carers as well as workers in the field has really been very elegant, as well as the generosity of the ministry in having a very unconstrained approach to local communities developing local solutions. And that's particularly exciting and not something one sees every day of the week from government departments. So the Ministry of Health's to be congratulated in that.
Well, thanks for that, David. I wonder if you can comment a bit further about the district support for the co-design process that has taken place there. There's a variability, I guess, across the state of experience in co-design processes, and some districts may be particularly unfamiliar with the concept and with how it can be applied in the most valuable way for the district. So I wonder if you'd have some reflections or advice for other districts around how the district can best support the process.
I think it's really the distillation of what we should be doing in terms of providing caring services anyway, but it is going to the community and finding people who have lived experience, who have cared for people with lived experience, and making sure that there's a framework, a safe framework for people to become involved in the planning, the design, the implementation and the monitoring of projects like the ED Alternatives project. I think one of the things that I would say to clinicians is this is obviously a ministry sanctioned project, but it is a project for you and your community. And taking a generous approach to differing views is very important from the outset. You know, mental health should be about listening to people. And sometimes we are all very focused in projects. It's very important to listen. Inevitably, there will be times when not everyone in the room agrees. That doesn't have to be the cause of any major ructions. It is an opportunity to come back and to reflect on the sources of the disagreement. We had a very interesting discussion around governance at one stage, the term governance, because coming from a health service, of course, I'm deeply steeped in the term clinical governance. But when we all reflected on it, it was apparent to all of us that governance is just about making sure there are good systems in place to support workers and to support the people who are having the services delivered to them. We were able to have a very good dialogue about that. I think the other thing that I would suggest is working with Roses in the Ocean does involve some pretty strict timelines, and that's for a very good reason. The co-design process does need to have a lot of structure and a beginning and an end. And it is structured that way. So recognising several things. One is that we want to get these services rolled out. But secondly, engagement in the process itself is potentially upsetting for some people as they relive their experiences of either receiving care or even providing care. And so having the support of the Roses in the Ocean during that, and the ability to provide people with breakout spaces and the ability to speak to people is really very important. So that's why it's kind of constrained at the beginning and the end, so that we know that we can look after people during that process. And I guess the other piece of advice I'd give other local health districts is, this is a very new process. It is going to be a bit confronting for people who've done projects in a different way. But if you get an innovative suggestion, if you get a different way of thinking about this, reflect on it. It's your community, it's your stakeholders, it's your workers who are recognising that this needs to change, along with people with lived experience. So listening and caring is the bottom line of what I'm saying here, Stephen.
Those are some really excellent points, David, and I think certainly some that are really well expressed through the co-design processes that Roses in the Ocean use. Before we move on to Bronwen and talking about the Roses in the Ocean work itself, I wonder if just finally you could provide some comments, again, in terms of advice for other districts about some of the similar, I guess, to the governance point you were raising there, some of the other aspects of the model that may be a little challenging or a little unfamiliar to districts traditionally. For example, the fact that we're engaging a suicide prevention peer workforce here that's based on lived experience of a suicidal crisis or a suicide attempt, that we're delivering this non-clinical model, and how that can be managed in services that are, very adjusted to delivering clinical services. Whether you also had some reflections around those points that could also give some guidance for other districts that are at the beginning of the process.
Yeah, I'm going to start in an unusual place in responding to that. The place that I'm going to start in is around your services peer workers. So the peer workers that you have recruited and that you brought into your service, what role do you place upon listening to their views, their ability to participate with consumers in terms of care planning, and their own development and their retention within the service? Why do I think that's important? Because they, in a way, represent an analogue of the workforce we're talking about, albeit in a different context, in a different organisation, and in a non-clinical role, as we've discussed. I think that some health professionals are very reluctant to engage not-for-profit or non-government organisations, particularly on challenging topics such as suicide. The reality, however, is that any experienced mental health professional knows that suicidal ideas and feelings are a ubiquitous human experience. And so being able to engage with people who have those experiences, relevant training as a peer worker, and the ability to work in a safe and structured environment for them and the people who come to the service, that's something we should be celebrating. This means, however, that people don't need to come to EDs to access this service. And I guess some health services might find that a little bit challenging. There is no necessarily an electronic medical record opened up. But what we're aiming for here is not process and procedure for its own sake, but real outcomes for people, and people going into spaces where they feel recognised and listened to. The other challenge that some people might experience is of working across between a health service and a primary healthcare network. The primary healthcare networks, of course, have got a huge role in providing primary care in the community and healthcare planning and commissioning. Because that is a federal perspective and health services work within a state perspective, sometimes there's some cultural differences that need to be worked through as well. But I think with a focus on the end result and having people with lived experience and carers in the room, and ensuring that they are given primacy in what they are saying about what should happen, is a good way to blend those two Commonwealth and state cultures.
Thank you very much for that, for that, David. You've, I think, given some really eloquently expressed points there about the opportunity that both this new type of service presents and also the opportunity that the co-design process itself presents. So thank you for your contributions there, and also for your leadership and stewardship of the process in Illawarra Shoalhaven.
The bottom line is we want you to succeed. We want you in your area with your community to succeed. So we want to help set you up for that success.
Absolutely. Thanks very much for that, David. So I'll just move on now to Bronwyn Edwards, the CEO of Roses in the Ocean. And as I mentioned, Roses has been working on both the training of people with lived experience and also the co-design of the Alternatives to ED initiative. So Bronwyn, would you like to start by maybe talking about how those two pieces of work intersect and align with each other? Because there is, I think, an important relationship between the two of them, isn't there?
Definitely. Yes, thanks, Stephen. Yes, the two really do are interwoven. So it's helpful to understand process and order and what have you. I guess the first thing, though, I just want to really stress is that we're very aware that different LHDs are at different stages. Some people have really been actively engaging people with lived experience of suicide for a while. Some of you have not done it at all, and there's plenty in the middle. There are those who are used to having groups of consumers and carers from the mental health space and not so much in the lived experience of suicide space. And our role is to come in and support you. So the ministry has engaged us to do just that. Now, if that means that you really need to start from scratch and we help you recruit and we'll screen people to determine that they help them, make that informed decision that they're ready to get involved, then we can do that and we can set up an actual lived experience advisory group for you. But if you already have people that are working with you and you want to either provide them with some training that they may not have had the opportunity to have specific lived experience training, then you can utilise us in that way. And for those that have, really large LHD regions, there's the opportunity for you to have us come and essentially work with you as if we're setting up two lived experience advisory groups. But how that happens is very much up to you and for us to discuss. It's to whether there's a couple of areas where you want specific groups together or whether you want us to get regional wide cross-section for you. So I guess the main message here is that we have, almost a decade of experience in building capacity of lived experience people so that they can really very meaningfully engage and add value to what you're doing. How we go about that, let's meet you where you're at and we'll see how we can best support. Ideally, as Stephen initially said, we want to get those people trained and in a position where they feel really confident to contribute to all the exciting initiatives that you're working on. So that's the first step. Essentially, you'll try and get a group of really good diversity across your LHD, and that will mean then that when we move into that co-design phase, those members of that lived experience network that you currently have or that we contribute to, the people who have that lived experience of suicidal crisis or attempt or caring for a loved one in that position, they're the ones that have that relevant lived experience that we want to draw into the co-design process. And then we will go further out to the broader community to recruit additional voices. Other members of your lived experience group may then get involved in the Towards Zero Suicide Care or in the postvention or various other initiatives. But it's really important to be matching the lived experience with the initiative. Of course, that lived experience group then just become this really valuable resource for the LHD and other organisations in your region as well to get that overall perspective being contributing into your work. So yeah, the lived experience advisory group, getting them up and running, then being able to intersect them into that co-design process, but absolutely going out and recruiting more broadly, because we need to have the voices of the people who've used emergency departments in the past, but we also need the voices of the people who never will or have never will or would never go back. So we've got to find the voices that are a little bit hard to find, because we want to make sure that the safe space that we design with you in your region is actually one where people feel comfortable and confident to come to if they don't want to go anywhere else.
And thanks, Bronwyn. And I especially appreciate the points you were making there about the flexible approach that Roses takes to the different capacities and states of readiness that we have across the state in local health districts. And so districts are really encouraged to work collaboratively with Roses in the Ocean to make every use you can of the fantastic resources that they're bringing to bear on this process, and to adapt those and make sure that they are fitting in well with your local context within your district. Now, Bronwyn, could we go into some more detail now about the co-design process itself and what Roses in the Ocean has done in Illawarra Shoalhaven, and that quite well established and I think quite innovative formula that you use in all of Rose's co-design work?
Yes, absolutely. And thanks to COVID-19, we actually have 2 co-design processes now. So when we were just about to get going actually, and we were all thrown into this very unusual space that we live in now with COVID-19 restrictions. So we have for a couple of years now been designing, basically co-designing our co-design process, because we were very, very conscious that co-design with people with lived experience of suicide in the suicide prevention sector and for suicide prevention services is different, and it needed to be approached in a different way. So we had actually designed a process that is different to that standard design thinking that people would be used to. We have been having a sort of 1.5 to 2 hour presentations with individual and small groups of LHDs to take them through the detail of that step by step. But the overarching principles are that at the centre of the co-design, we have to absolutely always remember that we're actually trying to design a service for people with specific needs. And so it's really important that we provide a supportive and safe space for all different stakeholders to be able to speak their truth. And this is the real differentiator in the way that we approach co-design, in that we work very hard to get all the relevant voices at the table, and that's on the health professional side as well as people with a lived experience. But we do give both of those groups of stakeholders the opportunity to come together and start exploring through emotions and feelings, the reasons for those and the really specific needs that they have in an environment on their own. And that is all about managing what is often the elephant in the room, but it's a very real elephant, and there's that power imbalance that does exist. But what's been absolutely wonderful to see through the Illawarra Shoalhaven process is there is so much alignment. Health professionals are experiencing the same emotions to a lot of the people with lived experience. No one wants to be either going themselves or taking the people that they're trying to support through a process that wasn't designed for them. And so what we discovered with Illawarra was there was so much alignment that by the time that those groups came together, there was an enormous mutual respect amongst everybody at the table. And that just allows you to just move forward really, really productively. And that when boundaries or little barriers pop up, which are inevitable, you've got this fantastic collective desire to just solve those, work around them, work through them, but make sure that they're aligned to the overall principles and values of a safe space and a non-clinical service. So the process itself, depending on whether we can actually come to you and be face-to-face or whether it's an online process, it's very similar. There's a few additional touch points in it when we need to be doing it online, because we just don't want to keep people for 8 hours on a Zoom, of course. So we've got to come back to you a little bit more regularly. but that we have multiple feedback loops built into the service, and they're really critical because we can only have so many people involved in a co-design process. A little bit less when they're online, but even when you're face-to-face, you still have to manage numbers and being able to have really deep conversations. So the feedback loops enable us to do a live webinar, explain what went on in that co-design particular phase, what the outputs were, and then provide a survey for the broader community to be able to contribute their feedback. And nothing happens until that feedback is received, that it can be, you know, thematically analysed and fed into all the other outputs of the co-design to that date, and then we move on. So that feedback that comes from the broader community is just as valuable as what we receive in those actual co-design sessions. And there's actually 3 significant feedback loops built into the process, as is some process evaluation throughout. So that if what is happening in your LHD isn't quite hitting the mark, then we can tweak it immediately after the first phase that we're there. So it is your process. We're here to guide it and lead you through it, and we're here to bring all those voices together. And then we do work with Beacon Strategies, and for those of you that we've provided our presentation to, you will have already been introduced to Beacon Strategies. They are offering an invaluable additional support in being able to really synthesize what comes out of co-design, and you have access to a number of additional days outside of them being with us in that actual process to really help you take those outputs and put it into an actual service model, and then they offer lots of other assistance that you're able to tap into. The other role that we have, 2 other main roles in the co-design, is firstly a guardianship role. So the ministry acknowledges the importance of ensuring that what comes out of co-design, what your community members tell you that they want and what your health professionals tell you that they want, that actually makes it to the ground and it actually starts being rolled out. So our role in that guardianship space is really to work with the LHDs to help them really, it's almost like a translation, but it's to help you really understand how that needs to translate into the ground and into the actual service. Now that could look like just allowing us to come and join your steering group meetings during that particular phase of, here we go, the design's underway, and now we're moving into how we're going to deliver that as a service. So we can, if you want us to, we can be there in that sort of capacity to be part of those discussions. But otherwise we are there to be called upon at any point and answer any questions around what does this actually look like, feel like, taste like when we're actually delivering it. So that guardianship role is really important. And an extension of that is the redesign. So the ministry, once again, is so committed to making this happen. And as David said, you know, the LHDs just want to make this work. You know, it's about helping you succeed. There's a redesign process as well. So 3 to 6 months after you've opened the doors of the safe space, we will come back and spend another day if we're allowed to be with you. Otherwise, we'll do it online. But it's about then saying, okay, how's it working? Get the people in who are involved in the co-design. But ultimately, we also want guests who've actually used the safe space since you opened to be part of that process as well, so that we can keep continually improving it. And part of, you know, the actual model is really important that we embed an organic, ongoing avenue for people to feed back into it, so that, you know, once we have finished our work where we are, you've got something built into that process so that people can always be feeding back. In Illawarra, the suggestion was that it was a monthly barbecue, or a bi-monthly barbecue where everyone just could come along and you just, how's it working? Let's get that feedback and let's keep improving.
Thanks for that, Bronwyn. It's such a fantastic process, and I especially appreciate, of course, the adaptability that Roses has shown in responding to the COVID environment that we're working in, but particularly also those separate processes for people with lived experience and for health professionals and others, and the type of safety that creates in the process, I think is a huge plus. We are, as a ministry, very committed to a robust and transparent co-design process, and this is bedded down in the strategic framework for suicide prevention. It sets out clearly that co-design is to be the way that we develop suicide prevention services in New South Wales, and so we're really excited to be engaging this kind of very robust co-design process that also builds in those mechanisms for translating the outcomes of the co-design into practice, and then also that that redesign stage as well, which we also think is absolutely critical. I've said many times in the development of Towards Zero Suicides that we don't see co-design as a short-term activity that takes place at the beginning of a service, but something which is more long-term than that and extends into the life of the service. So we really appreciate what you're contributing to this work. Now I'll move on to Carrie Lumby, who has been very closely involved in the work in Illawarra Shoalhaven, and as I mentioned earlier, is a lived experience member of the Suicide Prevention Collaborative there, and is also a member of the district's Towards Zero Suicides steering committee, which in itself I think has been a fantastic structure for driving this work forward. So Carrie, could you start by giving perhaps just your overall impressions of the co-design process that's been carried out in Illawarra Shoalhaven, and I guess give some of the key takeaways that you think are important for other districts who are just starting the process. You're on mute, Carrie.
Thanks, Stephen. Yeah, I mean, I guess the overall kind of the broad brush impression of it is it's been a fantastic process. I think people are already getting a sense of what's gone on here, and I've been involved myself in a range of co-design processes before, but I think what is, and David's spoken to this, there's a level of sophistication here. I think the ministry's approach, the fact that this is nested within a kind of a real kind of culture change in our approaches to suicide prevention, that it's part of a networked series of initiatives, means that, you know, these sort of siloed kind of social impact approaches that are taken often, that sometimes have co-design as part of them, just don't have the level of collaboration, of really broad community engagement and buy-in. And so that's been a really fantastic thing to see. I think it's really served us well that this is all, that we have these pre-existing relationships, collaborative relationships with the collaborative, that's allowed us to already have developed some of those, the equal partnerships, which is really the core value of co-design, to have the capacity for traditional experts and experts by experience to be working together, to be genuinely listening to each other, to take that generous approach that David spoke about. And I guess what I would say in terms of the key things to be thinking about, the key takeaways we have here, is that idea of really taking some time and really utilising the support that Roses gives people to set up for success in terms of getting people, the right people in the room, the right people with lived experience. So it's always good to get a diverse range of perspectives, as we know, but lived experience is a broad church. And in this case, in the case of a safe space initiative, as Bronnie has said, you need to get people with a lived experience of suicidal crisis or attempt. You need to get people in the room that have had significant exposure to ED in hospital. I think in particular, involuntary treatment, like me, I've had a lot of involuntary treatment as a result of my suicidality. And I think that sort of raises the power stakes, and that's what we're trying to break down, that power differential. It's also equally important, as Bronnie said, that we need people in the room that wouldn't access services traditionally, that they're the voices that are missing quite often in sort of systems change initiatives, also people that are really impacted by the situational stresses, the systemic social issues that we know give rise to suicidality. We know that there's many people who die by suicide who haven't been in contact with the mental health system, whose suicidality is not a result of a diagnosable mental illness. So they're very important to get in the room. And also people whose minority status, I guess, has really, the discrimination and oppression and marginalisation that comes with that really compounds those kind of systemic social issues. So particularly the voices of Aboriginal people. And we really did make the effort down here to get all of those perspectives in the room, including what was interesting is in terms of the lived experience cohort, we had gender parity, which is really quite unusual. And that's because that time was spent to get those voices in the room. In the case of suicide prevention, it's a good thing to have as many men as there is women. So, yeah. And then I guess also I would say that it's important for people to know that this isn't just a feel-good exercise. In the case of CoDesign, there's good evidence coming out now that if you design services with service users, with people who are experts by experience, you'll start to generate services and that meet the needs and wants of those people, but also therefore they're services that are more effective and sustainable. And also importantly, that if you have health professionals in the room that are at the coalface delivering the conventional services, they can address, well, they can bring up all of the issues that potentially could happen as barriers to implementation. So you'll get, in our case, we saw health professionals saying, you know, there's this clinical risk aversion, that's not going to work in practice. There are these organisational constraints in practice, and we were able to really creatively explore that. And because we had these fantastic champions of this way of working in our steering group, like David and other senior people in the ISLHD, we were able to go back and negotiate that in real time to get some resolution, like we've talked about, the idea of governance not needing to be clinical governance. I guess I'd also say I think it is really important to communicate that when these things don't happen, when you don't commit to power sharing and really being generous with listening to each other and opening yourself up to really getting curious to other people's perspectives, then you can end up further reinforcing that those us and them dynamics, which we know are so destructive to creating the compassionate system that we're all passionate about. To really, I think it really does increase the cynicism that both people that are working in this very difficult, complex system have about change, about the possibility of change, and then people with lived experience who also feel quite ground down by the system themselves. So it's super important, and this initiative is the beginning. We have to remember a whole range of initiatives, of a whole way of a mindset shift, of a culture change. So setting this one up for success is super important in establishing those relationships of trust and respect, of having people with lived experience, you know, actively championing this, of having people like David actively championing this way of working. And I think it will serve everyone very well in the next couple of years as this rolls out.
Thank you, Carrie. That is a really powerful account, I think, of some of the most essential features of the process there and some of its benefits to the system and the people who have been involved in the process. One of the principles that I, have particularly paid attention to in the CoDesign literature is this concept of legitimacy, that a robust CoDesign process can produce services which have legitimacy and are widely supported in the communities where they're operating. And I think a number of those points that you were making there really speak to that principle. I wanted to see if you could reflect a little more perhaps on that final point that you were making about the power, I guess, of people with lived experience and health professionals working together in this process, which has been genuinely collaborative. Because as you are saying, it is something that is quite novel, I think, in our system, and something that's quite different to the way that we've designed and implemented services previously.
Yeah, I think the most powerful thing when we talk to people, because people are still giving us feedback about what a fantastic process it was to participate in the Safe Space co-design. And I think what was so powerful is the realization that happens for people that, hang on, not only are we not sort of, it's not an us or them situation, it's that we all actually have a common ambition here that we can pull behind, which is to create a more compassionate system that works for everyone. And I think that the power of that for both health professionals and people with lived experience is, I would say, it's actually quite a healing process for people. I know there's one bloke down here who'd recently had a suicide attempt. He'd been in hospital. He'd found that very traumatic. He felt very much like there wasn't the kind of follow-up he needed, and he was dealing with a lot of situational stresses on top, and it was a really, really challenging time for him. He was encouraged through the collaborative to participate in this process, and he has said that not only does he now feel heard, and he feels like there is a possibility for change, and that other people won't have to go through what he has gone through, but also it's really switched the light on of recovery for him. He's holding hope for himself, and the power of that, and for health professionals to be witnessing that is a very healing experience for all of us, for the community. It makes people feel a sense of collective ownership over the improvements that are being made, and there is also just a sense of just sort of credibility now that the system itself, and then the people that work in it, perhaps didn't have before with people. And so, as you can imagine, that just creates a healthier, more humane kind of environment for all of us to just be community members.
Thank you for that. And I think, again, some really excellent points there about how transformational a process like this can be if it is led in this strongly participatory way. Now, we're coming close to time, so I might just move to some wrapping up statements from all three of our panellists here. And I guess, would be good to frame those closing statements in terms of just some key messages for other districts and other participants in the co-design processes that Roses will be leading around the state, and also, I suppose, some next steps, perhaps in particular from you, Bronwyn, about how districts can continue to link up with Roses in the Ocean to engage you locally for these activities. So, David, I might just loop back to you now for any closing comments that you'd like to make. You're on mute there, David.
Thanks, Stephen. I'm sure there are lots of experts listening to this, but I would just like to return to something that Carrie said, which is experts by experience. This is a real opportunity for you to learn, understand, sit down with, design and implement something really quite new and quite different. And opportunities like this don't come along all that often in mental health. So please embrace the change and make sure that you create a safe space with Roses in the Ocean to undertake this process.
Thanks very much, David. Some really wise and very heartfelt statements there, which is just great to hear from the local health district. Bronwyn, I might leave you till last and just maybe go back to Carrie here. I think, particularly from your lived experience perspective, is there a set of key messages that you would want to just summarise for other districts and other participants in the co-design processes to come?
Yeah, look, I think it's about being bold in your thinking, and I do think that starts from the top. We've been very fortunate to have people that are genuinely championing this way of working, because these are innovative approaches. There is a lot of anxiety around it. And so, yeah, please, anyone that's in an influential position, decision makers, it's important to actively champion this approach, to champion experts by experience, as David was just saying. I would say to people with lived experience that because you have this very supportive sort of scaffolding around you because of Roses in the Ocean, this is the perfect opportunity, particularly if you felt that you haven't been heard before, to have a go, to have another go if that's what is required. And we understand what that takes, the time and energy and putting yourself out there. But I would really encourage people. I've had bad experience in the past of feeling like they were just ticking a box, these processes. But I have to say it has been transformative for me. It's been an important part of my recovery. But also, this is about the whole community. This is about creating a healthier community as a whole. And so we need everyone in the community to feel that they have a sense of collective ownership about this. So spread the word, get as many people involved as possible. This is not just about the usual suspects that get to participate in service improvement.
Great. Thank you very much for that, Carrie. And, you know, again, excellent advice for the processes to come. And Bronwyn, we'll just conclude with you if you'd like to give some final advice to districts about their engagement with the process and moving forward with linking up with you to continue arranging these processes.
Absolutely. So I'm pretty sure we've actually managed to speak to all LHDs now. We had a number of sessions just last week where we had 2 or 3 at a time. Bridget and Sam and Beck and Ivana, the team in New South Wales, are absolutely there to assist you. If we haven't spoken to an LHD, we'll be speaking to you very soon. I'm sure it's booked into the calendar. But the bottom line is we're here to work with you. We're here to support you. This is, I think, the biggest game changer in suicide prevention. This is a game changer that we have been waiting for, it seems like forever. New South Wales is absolutely leading the way and Australia is watching. We have the most amazing opportunity here to actually create spaces where people want to be. And I think it's important to acknowledge that this will make some people feel uncomfortable, but we would ask you to remember that if somebody doesn't feel like they can come and access any of the existing supports, they are sitting at home alone trying to stay alive. And fundamentally, that's what it comes down to. So we are here to create a safe space where someone feels comfortable and confident to step through the door and be greeted with a smile and an arm around their shoulder by someone else who knows exactly what it feels like to be contemplating ending their life. And those people are very well equipped when they're well trained to support anyone through a suicidal crisis. So, we have an opportunity for significant system reform to build amazing bridges between clinicians and existing services. This is about an and, it's not about an or. And it's just time to draw a line in the sand and step forward and say, this is what people want, it's what people need and what they're asking for. Everyone at Rose in the Ocean has a lived experience of suicide, including all of our facilitators, everybody. So we're here to work with you. We're here to keep your voices safe for people with lived experience and provide a space for you to be heard. And we have the utmost respect for the people who work in the system already. So please, there's no silly questions. We're just here to work alongside you and get these amazing services up and running.
Thanks so much for that, Bronwyn. And I would just, on behalf of the ministry, like to reiterate the message to the districts that this is a really important and innovative resource that's being made available to districts across the state in every one of these sites for the alternatives to ED. And you're encouraged to really embrace this opportunity to use those resources to the greatest extent possible. Just to conclude, I would of course like to thank our three panellists this afternoon, Bronwyn, David and Carrie. Thank you very much for those really fantastic contributions. And finally, I would just also really like to reiterate a few points that have been made earlier. Firstly, to recognise the really outstanding leadership in the Illawarra Shoalhaven Local Health District that's allowed this process to be so well supported and to have worked so well there, including from David and also Julie Carter and Alex Haynes, and all of the members of the Towards Zero Suicides steering committee in the district as well. I think that's been just an excellent process and an excellent structure. And just finally, I think to kind of tap into that final point that Bronwyn was making as well, that what we're ultimately all trying to work towards here is fewer people dying from suicide, fewer people being in distress and being unable to find services that give them the relatability that they're looking for and the compassionate response that they are really needing. We all want to see improvements in that regard and to make sure that people are finding the support that they need and for that support to be the most effective it possibly can be. So with that, I'll wind up this webinar for today. Thank you all for watching and for making use of this. To coin again the phrase that Carrie was using there, please spread the word and feel free to distribute this very widely, and do get in touch with Roses in the Ocean and or the ministry as well if you need further information from us as well. We're very happy to talk to anyone in the districts at any time. So with that, thank you everyone, and have a great day.
Thanks, Stephen.